Hi, everyone. My name is E. David Crawford. I'm a professor of urology at the University of California, San Diego. Androgen deprivation therapy, clearly the foundation and the backbone of treatment for many cases of locally advanced and metastatic prostate cancer. It is one of the most effective and well-tolerated therapies for any advanced cancer. The goal of ADT is pretty simple: lower testosterone, lowest possible level, and keep it there. In the past few years, we have learned a lot about the challenges facing the physician administering and the patient receiving ADT. These include escapes and testosterone rises from a number of different causes, lack of clear understanding of what is the definition of castrate, and dealing with the many side effects, which go way beyond hot flashes, include things such as osteoporosis, weight gain, sexual side effects, and more recently, the understanding of cardiovascular events. Joining me to discuss these many topics are two international leaders in prostate cancer and GU cancers, Dr. Ben Lowentritt and Dr. Neal Shore. Ben serves as the medical director of the Comprehensive Prostate Cancer Program and director of minimally invasive surgery and robotics at Chesapeake Urology, which is a member of the United Urology Group practices. He also serves as vice chairman of the Physician Services and director of Prostate Cancer Services for United Urology. Dr. Lowentritt is a member of United's executive leadership. He's been president and director of many societies in his home state and also section. We're really glad to have Ben with us. Also, Neal Shore, who is medical director for the Carolina Urologic Research Center, and he practices with the Atlantic Urology Clinics. Dr. Shore is in Myrtle Beach, South Carolina. He graduated from Duke and Duke Medical School. Still a Duke fan, I don't know why. He completed his general surgery urology residency at Cornell, New York Hospital, and a fellowship at Memorial Sloan Kettering. Dr. Shore is the Chief Medical Officer for Surgery Urology for a large group called Genesis Care. He serves as the chair of the Educational Committee for LUGPA. I just had the opportunity to attend the LUGPA meeting in Chicago, and it was an outstanding presentation. He also reviews for many editorial boards, reviews in urology, Urology Times, and so forth. Dr. Shore and his colleague, Alicia Morgans and Chuck Ryan, published a review paper several years ago entitled Resetting the Bar of Castration Resistance, Understanding Androgen Dynamics and Therapy Resistance and Treatment Choice for Prostate Cancer. This publication is going to serve as sort of the core of our presentation today, and I'm glad that we have the author here, Dr. Shore. So with that, I'm going to go ahead and get started on my slide presentation. So our program tonight is entitled ADT as Foundational Therapy and the Need for Consensus on Consistent T Suppression Goals, Monitoring, and Delaying the Time to CRPC. So I'm going to go ahead and get started. We, as urologists, all know that the prostate, the testosterone is dependent on an intact hypothalamic pituitary testicular axis. And there's lots of different ways that we can interrupt this axis. And when we do, the testosterone that we measure in the eugonadal men is about 95% from the testes. That changes, and we see some contributions from the adrenal, the tumor, and other things, which we want to try to neutralize when we treat prostate cancer. Hormone therapy, there are a lot of different flavors out there and options. Estrogens are one of the first. Bilateral orchiectomy, as you know, goes way back to the Huggins and Hodges era. The changing point was the introduction of LHRH agonist and a little bit later antagonist. We also have usually oral drugs, oral anti-androgens, and we can call them first, second, and third generation. That's what I do. Combined androgen blockade, putting things together, and now we're into doublet and triplet therapy for newly diagnosed disease, and 1720 lyase inhibitors, which are androgen biosynthesis inhibitors that are out there available. So this is Dr. Shore's article, an excellent article, and I've got it right here in front of me, and we'll go through it here for the next few minutes. One of the things that we know from history is that when we first started doing studies with T lowering with ADT and bilateral orchiectomy, our methods to measure testosterone were not down to zero, but basically less than 50. And that sort of remains now. But we know from studies that were done more recently in the early 90s and mid 90s and 2000 is that when you do a bilateral orchiectomy, what you see is the T levels down less than 20. And now we can measure with mass spec down much lower. And we'll talk a little bit about the implications of that. Dr. Vogelsang, who passed away a couple of months ago, a very good friend of ours, was one of the pioneers in looking at testosterone levels in prostate cancer. In 2012, a number of us got together in Bethesda, and we came up with this Bethesda consensus and basically said, hey, we think that less than 50 isn't where we want to be. We want to be less than 20 or lower. And then other organizations went along, the EAU and Canadian Urological. The AUA and NCCN have not committed totally, but one step in the right direction was a couple of years ago, the FDA says, well, because all these studies were done earlier when we can only measure less than 50, is it really right to say less than 20? That creates some conflicts and issues and things like that. I think that could be overcome. But anyway, now they say less than 20 is a good secondary endpoint in clinical trials. And we'll talk about Dr. Shore's trial that was published in New England Journal of Medicine here in a second or two. So I've said a lot here. Let me just talk to our panelists here. If we have this hypothetical question that we ask in an ARS in a medical meeting with urologists. Ben, how do you think urologists in general would answer this question?
No, I think if we're answering it in a crowd, we would always answer 3. You know, the should be is less than 20. I think we have a general acceptance that that's important. Practically, I think a lot of people still accept less than 50 in their practice. You know, I think the evidence, as we'll discuss and as what you're discussing, is pretty clear on the value of less than 20 being both an accurate depiction of what compared to castration, which is, you know, really what the terminology means. But, you know, fundamentally, we're talking about what's most effective to combating the cancer. And I think that's where we just have to be intellectually honest with what we're trying to achieve when we're treating with these drugs.
Neal?
Thank you, David, for inviting me and for all the amazing work that you've done and the great work I've been able to do with you over the years and educating our colleagues on, you know, what is the value proposition for androgen deprivation therapy? Does it matter how low the testosterone gets? You know, you've been pioneering on most, if not all, of the T suppressing drug formulations, and as everyone knows, the regulatory approval, it's a pharmacologic endpoint of just getting below 50, and I think, as that earlier slide you showed, it's a little antiquated because the ability to detect serum T, the assays have really changed significantly over the years. But, you know, that said, we still have this very conventional historic definition that the FDA uses. I think an interesting other question to this is what the target. I'm still surprised how often our colleagues don't check a baseline testosterone before initiating androgen deprivation therapy, and even after initiating androgen deprivation therapy. They just check the PSA, and if the PSA goes down to a level or declines to a level that they're comfortable with, then they feel that the androgen deprivation therapy that they've selected is effective. I personally think it's very important to check a baseline testosterone before I start a T suppression therapy. And I think it's important to check it soon afterwards, so I know how effective it is. And yes, I agree that we should, if we believe in the importance of starting ADT, which is a seminal moment for most men, unless it's a very short-term therapy. So why wouldn't you want to know what your baseline testosterone is? Why wouldn't you want to know how effective your androgen deprivation therapy selection is? And yet I don't think that's practiced by the majority of our colleagues.
Neal, let me ask you this. Should we be working together to make a strong recommendation that we should have a target T level of less than 20?
I think the first thing you have to think about is who is the stage. What is the stage in the prostate cancer journey that we're addressing? Is it an adjuvant strategy? Is it a BCR population? Is it a metastatic de novo? Is it an MCRPC population? And one of the things we'll probably talk more about too is how patients tolerate very, very low T suppression, where it's essentially, almost undetectable to less than 3 nanogram or less than 4 nanogram per deciliter versus 40 nanogram per deciliter. And I think it matters, and I bring it up because what is the stage of disease that you're making this decision? And it's an incredibly important decision, especially if it's not for short-term indication. Personally, if it's for someone with metastatic disease, the least controversial time to start testosterone suppression, I think that does make a difference, and I think it should be less than 20 nanogram per deciliter.
Today, and exactly the reasons that Neal was discussing, I'm a little bit ambivalent to that because I'm so rarely using monotherapy ADT. Not all of the drugs directly block T production. Some of them block, T receptors, et cetera. I'm working to get the patients on the ideal combination of therapy now. So, I won't say I'm truly ambivalent, but, I don't know that we have the full understanding of the relative importance to a T level of 18 versus 35 versus a patient who's on an additional therapy, an additional hormonally active therapy and not. And I think it's important because, of course, if we're using ADT alone, I want this the lowest as possible, without question, end of story. And those other studies and those other treatments tell you exactly why. I mean, they're still working on the hormone axis to essentially get the lowest activity of testosterone, the androgen receptor, and all the downstream effects of that.
Let's talk about some of the nuances, challenges with androgen deprivation therapy. That's relatively new. That's the cardiovascular stuff, the giving on time and things like this. This was our paper that was published in 2020, about the same time that you did yours, and you actually mentioned this in your paper about late dosing of ADT. We all know that the pivotal studies were done on a 28-day month, not a 31-day month. And I don't think people understand that, and insurance companies certainly don't want to understand it. But what does it matter? So we have this very nice database, a real-world study of 22,000 men, looking at it. Did they get it on time, or did they get it late after 28 days? And then what if we gave them a little vacation of 4 days? What would happen? And so this is astonishing. But what we see is 84% of the patients were late, and 84% were administered beyond that 28 days. And so what's the impact? And people say, oh, so what? Well, the so what is if you gave it weight, what we see is about a third of the patients went above 20, but if you went really weight, beyond that 4 days, you see that the number above 50 is over a quarter of the people, and half of the people have T levels that went up greater than 20. So Ben, what are your sort of thoughts about this? 84% of the agents were administered and not on time. How did you feel about it? What do we do about it? Do we care about it?
We obviously should care about it and should be doing everything we can to fix it. But it also is working, it's working against us, especially when you start talking about 4 and 6 months to hit that sweet spot, right on, or even within a week or two is difficult. And you're, working with different people's schedules. It's a challenge. So it is very important. How practical it is the real difficulty here.
Neal, your comments?
Yeah, I completely agree with Ben's comments. There's just some real practical considerations. No matter how hard we try, when you look at your data, patients just get lost. They forget. Do they get called back? And so these escapes happen, especially if you've got metastatic disease and you believe that T suppression matters. And it should be done in a timely way, then it really does become extremely important. And then trying to figure out whether it's the 1, 3, 6 parenteral administration or a daily oral, I don't know that we're ever going to say one is perfectly well suited. We have to pull together all the different aspects of the practice. As I go back to earlier, if it's just somebody receiving a short course for intermediate risk disease for a grade group 3 radiation patient, how important is that as opposed to someone with significant metastatic disease? I think it's pretty clear the latter is more concerning versus the former. I think it makes a big difference. And I think that particularly so for patients with advanced disease.
I mentioned that ADT, and we all know this, is the foundation we build on, the backbone across all of these new agents and across disease state. And I think it's important to have a good foundation to build on, and that foundation is castrate levels of testosterone, and this brought about by properly administered ADT. So Neal, this is from your paper. This talks about the variation in guidelines. Now, we don't have to go through all of these, but what's sort of the take-home message here?
Well, I have to really applaud our European colleagues. I think that they have been a little bit more proactive. They've been more detailed, and they've adapted quicker to the data that's out there. And you kind of see this in the EAU guidelines, and it's not just in T suppression and the importance for the monitoring, but in a lot of other things as well throughout GU oncology. The other recommendations are all reasonable, but they haven't really taken as bold of an approach as as EAU has.
This is a great table within your paper, and I think it means that, hey, if you have ineffective suppression, it's time to look elsewhere. Your thoughts about that?
Yeah, I think that's right. Are you mixing your drug correctly? Is there delivery challenges, whether you're giving it sub-Q or IM? Are there timeliness issues, as your great paper points out as your first author there? And even anything as basic as the simple nursing and administration issue. So I think this is really important. Another good reason for checking T, because if you're looking at your checklist and it's not an administration issue, it's not a timeliness issue, it may be time for sure to consider changing your therapeutic.
This is an interesting question. I want to throw this at you, Ben. I mean, it's just a follow up with the Neal's last figure 3 there. Is the concept of failure to monitoring T levels to leading to erroneous diagnosis of CRPC. So that means if the T is elevated above castrate with a rising PSA, how do you interpret that?
For many of our colleagues that don't check testosterone regularly, and I think that question of how do you check it regularly is also relevant. I mean, unfortunately, with my clinic, just practically, we're getting a lot of the blood work at the same time that we're giving the next injection on the same day. Ideally, we try to do it a week before, but we're not going to delay, as we've talked about already. We don't want to delay the treatment just to get the blood work if the patient hasn't had it already. So they often get it the same time they're in the office for their injection. And so you're sometimes working, you're working with, you've just given them a shot. Now you get their testosterone result back and it's a little bit high. But even if you're not proactively checking testosterone, when the PSA rises, I think that's when most of our colleagues, hopefully agree that testosterone is being checked. And so certainly if you're diagnosing someone as CRPC, you want to at least meet that definition of less than 50. And I think that's both required if you're considering any additional treatments, but it's also just to make sure you're giving adequate therapy. I do think this is an interesting point, though, to think about, okay, what do you do in a situation where someone is truly failing, either by PSA or even by imaging, and their testosterone is, in that 35 range? Yes, I would want to consider doing better with my ADT, but yes, I also want to get them on the more advanced therapies as quickly as possible if they're, given that for many of them, there does appear to be better outcomes if they're found earlier and gotten on therapy earlier. So I guess the answer to this question is it would be considered erroneous if it's greater than 50. I wouldn't consider it erroneous if it's less than 50 and above 20, but I would be simultaneously working to get the T down below 20 as I'm likely also adding on other therapies.
Neal, what do you think?
Yeah, that's the exact point I wanted to make. I mean, we all love doing trials, and, clinical trials is a standard of care for all of our colleagues who are listening. And that said, if you have somebody who's, 60, 75, then what do you do? And the PSA is going up and they're on an antagonist. Do you switch them to an agonist? Or if they're on an agonist, do you switch them to an antagonist? Or if they're on one agonist, do you switch them to a different agonist?
Bilateral orchiectomy people do still.
Or you do bilateral orchiectomy. You're absolutely right. For trial purposes, you're pretty much, having to do that. If you're in the clinic, I'll think about all of those strategies. You're absolutely right, including even bilateral orchiectomy. It's a challenge.
So I guess we've sort of built up to this one. So there's 6 answers here. Neal, how would you, and what would you pick here?
Like I said, I mean, I always check a T at baseline before I initiate ADT. I mean, it's an inexpensive test. If you're getting, invariably, you're getting a CBC and a CMP and an LDH and a metastatic patient, as well as a PSA, I get a T. When the patient comes back, depending upon the ADT that I choose, when I recheck their PSA, I always check a testosterone level, because I'm kind of fascinated to see, if they started off and they were 600 or 190, where's their T now? And if they're well suppressed, I don't typically recheck a T until their PSA starts to, if it's starting to go up. And so that's been, I think, generally my pattern.
So Ben, this is what's your answer? Just pick one.
Ideally one, but at least every 3 to 6 months checking a T while they're on therapy.
We've already talked about this. If escapes occur, what should you do? And I think we heard that, at least from your paper, you're suggesting switching to a different agent, right, Neal?
Yeah, I think it's perfectly reasonable. And, I have had, enough, it's not the majority for sure of patients, but it is a significant enough a minority, and I've had success going from one agonist to another, whether it was a sub-Q to an IM or vice versa, and I've had success going from an agonist to an antagonist and vice versa, going antagonist to an agonist. I can't really always be absolutely sure why that was the case, but I do think it's certainly a tool that we should be aware of. And it all starts with at least checking a testosterone, because if you make that switch and the PSA goes down, you're arguably buying the patient a little bit more time before you start a CRPC therapy.
So this is your flow chart here, and I think we've already pretty much covered that. Ineffective T suppression. You've very nicely gone through the things to go through your mind about injection sites and timing and so forth. And if those things all seem to be okay, consider switching to another ADT. And I certainly have done that. I'm sure, Ben, you have too in your career. So I guess the other question is, are all ADT therapies equal in T suppression? And you had your study showed some delay with the sub-Q leuprolide, but there's really a dearth of studies. So Ben, is the belief that all LHRH agonists or antagonists show similar clinical outcomes and true, or rather than actually being evidence of there's no comparative trials? So what do you think the answer to that question is?
It's an absence of evidence in any kind of structured way, right? I mean, it's retrospective and attempts to make meta-analyses to show any difference, but we don't have those head-to-heads to really be able to say for sure. So it's an absence of evidence, but I think there's certainly experience that tells people and leads people to different conclusions. So I think that belief is in some respect just because of the lack of evidence.
Again, Dr. Shore very nicely said that we want to get the T down less than 20 here. We're all familiar with GnRH as a decapeptide, and different changes in the amino acids result in different drugs, but the one that is just on one amino acid on 6 is the one that Shally first developed, was triptorelin, and then we have leuprolide, and we have some of the other drugs down here. The point is comparative trials, and we acknowledge Verity, who provided an educational grant for this discussion. And I do want to mention that they have a couple trials that are close to being significant here. But triptorelin has been around for a long time, more popular in Europe than it was in the US, and it does have some advantages, as you can see here: a longer half-life, higher biologic potency, and things like that. Here's one of the early studies, a South African study done by Haynes. That was a study that was published, almost 20 years ago in the British Journal of Urology, and a relatively new one by Shim, looking at a group of men who were treated with different LHRH agonists, and including ones that we commonly use. And triptorelin has a 1, 3, and 6 month depot, and you can see here it does achieve castrate levels and keeps them there. And I think this would be true when we compare most of the ones that are out there. But when you look at testosterone suppression, it's a little bit slower with triptorelin than it is with leuprolide, but this is a comparison, and this is a Lynn trial. But you see that at the end of the day, with the 1 months, there was some advantage here of triptorelin. And then the last thing I want to talk about here is that about maintaining T levels less than 10. So we've been talking about less than 20, Neil, Ben, do you see any advantage of being less than 10, or we just don't know?
Well, it's so interesting. I remember, there was a point in time where we were using the word, androgen axis annihilation,
Yeah.
especially when we started getting, when the AR inhibitors came out, whether it was, flutamide, nalutamide, then bicalutamide, and then of course, enzalutamide, apalutamide, darolutamide, abiraterone. What we're now calling, ARTAs. And if you're a believer in the concept that you want that annihilation, then you would want all of the ligands, all of the fuel sources, testosterone, dihydrotestosterone, as well as any other sort of promiscuity, other ligands, whether it's something pushing on the other than the AR, to be stopped.
Mhm.
So, and when recognizing that there's no cancer type that's more hormonally sensitive than prostate cancer, you certainly would say, well, I got somebody who's really got bad biology. I want that T as low as possible. But, we still struggle because we see PSA declines, whether it's a level of T is 10 or 15 or 35. And we declare victory. Clearly, our couplet trials now and triplet trials in the MCSPC tell us that's not it's not enough to see the PSA go down and declare victory. There's more at play, and it's clearly involving the androgen axis.
Ben, I want you to help me with these conclusions here now. So the first one says the therapeutic goal of ADT is its foundational therapy to lower T in an orderly delayed time, in order to delay time incidence to progression to CRPC, prolonged survival. Testosterone levels should be less than 20. And Ben, I guess I believe we've talked about that, but you believe that, right?
Absolutely. And I think, I guess part of my point is that CRPC is a definition, and we have to deal with definitions. But we should be optimizing every part of our therapy. And the goal of ADT is to get the testosterone as low as possible. So even getting it to less than 10 is fantastic. Of course, that's great. And we believe it would be even better than less than 20. So we always want to be shooting for the best possible and strongest possible response.
We need to really define the castrate level with less than 20. And then the other thing is when the T rises or PSA goes up, you should get a T also. When you this looking into the crystal ball, I mean, this that they have the firepower you two have and knowledge of prostate cancer, I want to ask a couple of questions. So, when you think about every cancer that we cure, it's not treatment A followed by treatment B followed by treatment C, it's combos. I don't know, Neil, you know the answer to this because from recent studies, what percentage of newly diagnosed patients are actually put on a doublet, let alone a triplet? It's not very high.
Well, we're making progress. You're absolutely right. And it depends upon the source that you're looking at. And it depends on where you are in the country. If we're just looking at the US, we're getting closer. The most recent data that I've seen, we're getting closer across the entire country to about 50% of MCSPC, low volume, high volume patients getting a doublet. But I think the answer should be really closer to 90%.
Yeah.
There may be about 10% of patients who it would not be unreasonable to just do monotherapy ADT. The data is overwhelming. There are now about 8 different studies that support not doing monotherapy for MCSPC patients. But as they say, Rome wasn't built in a day. The guidelines have adopted the importance of doublet therapy, and in some cases, situations, triplet therapy. And it's an ongoing educational need. And this program that you've organized here tonight, David, which I think is great, still makes our colleagues and all of us have to think about the importance of T suppression and what value do you place on the level of T. And I think we're going to continue to learn more. There's a couple of trials coming forward in addition to the MCSPC space, in the BCR arena, in neoadjuvant strategies. So I think there's a lot more to come, and what the T was at baseline and what happened to it will continue to be, debated, but it's still very important.
Yeah. Do you think, well, I think the other thing about getting T down as low as you can and keeping it there is that you may progress slower to CRPC. So, the question: Are we going to be seen in a few years doing, say, 9 months of therapy and stopping it? I mean, not the intermittent stuff. Hit it heavy, and hard to begin with. Like Neal said, the annihilation.
Yes, we absolutely need to know how and when to intensify our therapies, and earlier is better. But part of that goal should be is with the possibility at some point maybe to de-intensify. So yes, I would love to see more structured studies where we're talking about 6 or 9 months, or even the 2 years, because there's certainly data out of Stampede and other trials that have come about 2 years of ADT therapy along with radiation for regional disease, et cetera, and even low volume metastatic disease in some cases, and maybe being able to get off of ADT. I think that would be wonderful for patients, both from a symptomatic standpoint and also to continue to have ADT as an option if they do progress.
So let me ask one final question here, or we can maybe you want to make some other comments, but what would you tell your best friend, Ben? What would you tell him to do for treatment for his prostate cancer really quickly?
I mean, for a patient that can tolerate it, I think our best evidence is triplet therapy. And I would recommend, kind of hit it hard early. Certainly check for biomarkers, understand if he may be fortunate enough to have one that we know can generate a survival benefit. But up front, it would be triplet therapy with chemo, ADT, and an oral agent.
Neal?
Yeah, I fully agree. I actually have been doing that prior to the results from Piece 1 and Arasens. It never made sense to me to start someone with high volume disease on ADT docetaxel based upon the great work from Charted and Stampede, and then just sit back and wait for them to develop CRPC. So I've actually been doing it for years. I was very happy to see Piece 1, which used Abby as the triplet, and Arasens, which used Darrow as the triplet oral. So if patient is chemo eligible, chemo tolerant, I hit him hard. Ben makes a great point. For that patient, your friend, high volume disease, you know what? I'm aggressive. I think your first shot tends to be your best shot. And so I tend to be a lot more proactive. And if I can find somebody who has a biomarker, I would try to think about incorporating that. Of course, putting them into a clinical trial is the best thing that one can do.
Any other final comments from either one of you? I want to thank both of you very much. It's rare to get the opportunity to get two people together like we have tonight. Ben, parting remarks?
No, I thank you very much, David, for having me. I really do appreciate it. I think the last line in here is also one we always have to remind people. Just because the ADT is not solely controlling it, they need to stay on for even as they fail. And I would say that's often when I've kind of realized, geez, the patient wasn't as low on their T as I wanted. Even now that they're not on anything else again other than ADT. But this message of checking the testosterone and trying to get it as low as possible is a foundational part of everything we do for advanced prostate cancer.
Neal?
I agree with all that. And I just echo Ben and say, David, thank you. Thank you for the amazing leadership that you've shown. This is just another example of that, having programs to push the envelope of how we're practicing. So thanks for inviting me.
Well, thank you both. And again, thank Grand Rounds and Urology, everybody that's been involved with putting this together. And also Verity for the educational grant to do this.